Intraoperative radiotherapy is the use of a radiation beam, ionizing radiation beam, during a surgical procedure. It's as simple as that. You are in a surgical procedure for a cancer patient, and at that time you make a decision to treat a certain area, sometimes the tumor itself that cannot be resected, sometimes what we call the tumor bed, the area in which the tumor has been resected, but we consider there is a risk of remaining tissue, cancer tissue, and can be a place for recurrence. So we treat that area prophylactically, adjuvantly, or sometimes we know that the patient has been well operated, the tumor is not that advanced, there is no apparent residual disease, but we know that the site of recurrence is a certain site in the anatomy, so there is a risk, not real residual disease, but a risk, and we treat that area prophylactically, preventively, not to avoid any recurrence, to control that area. So it's radiation at the time of cancer surgery. It was at the time I was a clinical fellow in England and in the States. There were the first publications in Western countries on intraoperative radiation therapy, initially from the area of the East Coast in the States, in Washington, D.C., Boston, Mass General, and very academic institutions, NCI in Bethesda. And I felt attracted by the idea itself. So when I read a lot about it, and when I came back to Spain, I had the opportunity to start a new department. And in a new department, you can introduce a new idea as if that idea was always there. So it was very well accepted by the surgical teams. They considered that there was an opportunity to develop a new program. At that time was fashionable, the program, and very attractive. So it was a combination of very positive attitudes by my colleagues, myself, and the initial experience that were published by very influential academic institutions in the state. The most important benefit in terms of clinical benefit is the ability to protect normal tissues. At the time of surgery, you can displace from the area that you are going to treat with radiation therapy mechanically those tissues that are not involved by cancer and will interfere with the radiation beam using external beam radiation therapy. So there is a definitive conceptual advantage in terms of normal tissue protection at the time of surgery. With time, we have learned other not so evident advantages. A very important advantage to me is that you have visual control of the area of radiation delivery. So it's what we call now image-guided radiotherapy. It's guided by your eyes. You control visually the area that you treat. So from that point of view, it's difficult to make a mistake in terms of selection of the target to be treated. And even more recently, we recognize also probably a very important advantage of the use of intraoperative radiotherapy, and that is that we treat more and more resected tumors. So surgery has improved a lot. Good surgeons now are able to do resection, what they call extended resections, resections that will contain a vessel, an artery, a vein, an area of bone resection, or if you need that, part of the bladder, part of another organ. So at the time of intraoperative radiotherapy, after that type of surgery with extended resections, you are treating minimal residual disease. You are treating almost no tumor burden, no large cancer tissue left in the area. And we know from many years that radiation is more efficient with less tissue and less cells being treated compared to a large amount of cancer. So a combination of three things: normal tissue protection, excellent delineation and definition of the target of the area that you want to treat, and decreased tumor burden left in the area. Probably that combination of features are key to explain the beneficial results of intraoperative radiotherapy compared to only surgery or only surgery with external beam radiotherapy. Yes, there is a very important model that is now being considered very actively around the world, and is early breast cancer. Early breast cancer with good prognostic features can be treated very successfully with one single dose of intraoperative radiotherapy at the time of tumorectomy. That has been proven by good trials, good clinical trials. It has been proven with different types of technologies, with electrons, with kilovoltage, with brachytherapy even, and that is a big revolution. You can treat one lady in one single day. He can come to the hospital early in the morning, and at 7 o'clock p.m. she can be discharged and go home, and the whole treatment, local treatment, has been performed. It's an important contribution of intraoperative radiotherapy. Now is selected, it's appropriate for patients with very good prognostic features. We know clinical features and molecular features in breast cancer very well, but even in patients with more adversity in the tumor can also be benefited by intraoperative radiotherapy using what we call an anticipated boost. At the time of tumorectomy, even if the tumor has shown poor prognosis in terms of cellular type, molecular expression, and so on, the boost that is given at the end of radiation therapy is given at the time of tumorectomy. So the patient at the end saves in between 5 to 10 days of extra radiation, and not only that, the accuracy of the delivery of radiation therapy is improved by being used at the time of surgery. So breast cancer is another important model. It's important because it's very common. It's important because results are very good. And it's important also because at times of economic crisis and economic difficulties, simplification, single-day treatment is a tremendous revolution in terms of management of these patients. Well, that's a topic of my life. You know, when I go around the world, this question comes always into the discussion and the argument. First thing I have to say is that intraoperative radiotherapy is, again, an institutional program. It's not a program for the surgical teams, it's not a program for the oncology teams, it's not a program for radiotherapy, no. It's a program for a hospital, and it's an interdisciplinary program, and it's important to be seen that way. That way you select well the patients, that way you grow appropriately in the program, and you do good medicine. The second thing is that should be, at this time, pioneering work in intraoperative radiotherapy was heroic. We transported patients from one floor to 3 floors, and we did a lot of very complex type of approaches. Today we have excellent technology, miniaturized technology, linear accelerators that will fit in the operating room with minimal disturbance in terms of surgical times. And my recommendation is to plan intraoperative radiotherapy programs first in very open-minded and very innovative institutions in cancer treatment. Second, with appropriate technology using miniaturized linear accelerators in the operating room to simplify the complexity. And third, to use intraoperative radiotherapy, not what we call protocol-based type of medicine. Yes, protocols are good in oncology and have helped many patients and have helped a lot the development of knowledge in cancer medicine. But today we live in a world of individualized medicine and individualized oncology. So this is something not to be incorporated to do in a hospital, to do exclusively protocols. This is an alternative treatment to rescue individualized patients, to be used under individualized indications, and that's another type of development that should be included today. So in my mind, a good combination of very positive surgeons that want to do excellent surgery plus a complement with radiation of their excellent surgery, and oncologists that are flexible enough to understand that in cancer medicine today we have patients that will be good candidates for protocols and patients that will be good candidates for special treatments, not included in average protocols. Patients that will need a special treatment, an individualized treatment, and intraoperative radiotherapy can be a good component of it. Well, to tell you the truth, in the last 10 years, I have only produced papers in English. This was an exception. Actually, sometimes I get a request to send a paper in Spanish to different types of the Spanish Cancer Society, or different types of organizations that will look for a more general type of information. So my life is English speaking in terms of publications and competitive scientific career. I understand that translation is important. As a matter of fact, when I write in English, I always look for a professional translator to supervise the paper. And the world, the scientific world now is English, so it's something that should be accepted fully and not discussed. It's interesting that your organization is extending very quickly in Latin America and Spanish-speaking countries. But it's good to have that balance of English to be present in your documents, because it will give a more universal view of whatever are you whatever are you giving to your readers and to your social target in terms of science. I think English is a universal language. I feel very good when I come to Latin America and I can express myself in Spanish. It's a different way to convince the people. I don't argue the same way in English or in Spanish, I know that. But in terms of written science and written knowledge, English is is the appropriate way to do it today, and it opens more and more visibility of your work.